Hello and welcome. My name is Dr. Eric Kennedy. I'm an assistant professor of disaster and emergency management at York University in Toronto, Canada. And I'm so glad to have you here joining us, whether on the Zoom call or the YouTube live stream or later on with our recordings to discuss different survey research methods in the COVID-19 pandemic. We've just come off of a week where we did not have a public session. We had some internal group deliberation about deliverables and strategies going forward into 2020. And so it's nice to be back to our format of interviewing different guest experts about the projects they're doing and the research they're pursuing. This week, we've got a really fun project that is out of Carnegie Mellon University in the US, working in conjunction with Facebook to collect a huge amount of data related to public impacts and symptoms and the like with COVID. We're lucky enough to have two guest speakers here. Dr. Ryan Tibshirani and Dr. Alex Reinhardt will be joining us for the conversation. Before we get to that, though, I did just want to open us to group members who wanted to make updates and announcements. We have one this week. Dr. Simon Bacon from Concordia wanted to give a brief update on the iCare study.
Wonderful. Thank you, Eric. Just to say that we're very fortunate the sixth survey round of the iCare study is now available. So we really want to encourage people to complete that if they can. It's easy to find. You can type in iCare study and you should be able to search for it. If not, it's www.mbmc-cmcm.ca/COVID-19, and I'll put that in the chat and pass it on to Eric so he can circulate that around. Thank you.
Perfect. Thanks so much, Simon, and great to hear that that project is continuing on. Really fun to see the sheer number of responses and the size and scale of the project that you're working on there. Speaking of size and scale, this week we are taking a jump to really large-scale surveying as we learn about what the Carnegie Mellon Delphi group is doing in terms of some of their COVID monitoring. The format for today will be a little bit different. We'll have Dr. Ryan Tibshirani joining us initially, and then a colleague, Dr. Alex Reinhardt, will be joining us midway through the session to add in some further detail. But Ryan will start off by giving us an introduction to the project and some of the different aspects of data collection, the partnerships and the research goals that are being pursued through the study. So Ryan, thank you so much for joining us. Glad to have you as part of this community and conversation, and we're excited to hear about this project.
Okay, thank you. Can you guys hear me okay?
Yes.
And can you see my screen okay? Okay. Well, thanks for inviting us. My name is Ryan Tibshirani. I'm a faculty, as was mentioned, at Carnegie Mellon University. I'm actually also a fellow Canadian. I was born in Toronto. I am one of the two leads of Delphi, which is a research group at Carnegie Mellon focused on epidemic tracking and forecasting. We've actually been working on flu since 2012, flu tracking and flu forecasting. And now, not surprisingly, we are focused on COVID tracking and forecasting. This talk has a lot of material that I think is probably too much for me to cover in such a short amount of time. So I'm just going to give you a super quick background on Delphi. I'm going to tell you a bit about what we're doing in terms of our project that's called COVIDCast, focused on COVID tracking and forecasting. And I'll try to mention the survey that we're running in partnership with Facebook and kind of convince you of first of all why it's unique and why we're very lucky to be able to have Facebook basically willing to do this in partnership with us. And then Alex, one of my team members, Alex, is going to come in the second half, and he's going to dive into some more details about the survey itself. So we've been working, like I said, since 2012 on epidemic forecasting, primarily on seasonal influenza in the United States. And we're currently one of the CDC's 2 centers of excellence for influenza forecasting. That was an award that we were given last year, and it's a 5-year designation. So we work very closely with the CDC. Our group has grown tremendously, basically, in this pandemic in order to support the COVID-19 response. And I want to just mention that now we have many smart folks, not just from Carnegie Mellon, but also from Stanford, UC Davis, USC, and most recently Google. So we are centered at Carnegie Mellon, but we really have wonderful volunteers from all over. So the history of our group was focused on forecasting. And when it comes to pandemic pandemic forecasting is extremely challenging. As you might imagine, it's the situation which by definition we have not been in before in terms of in this case, it's a novel coronavirus. So predicting its course is, about as hard as it gets in terms of a forecasting endeavor, at least in terms of, disease forecasting. So our kind of mantra was, before forecasting, you have to figure out how to nowcast. And nowcast is another word for develop situational awareness, figure out what is happening currently in the US in terms of COVID activity. And to nowcast, you have to have good data. Right? That's the only way that you can hope to get good nowcasts. So to summarize again, before good forecasts come good nowcasts. Before good nowcasts, you have to get good data. And we've been focused a lot on the data aspect basically since the beginning of the pandemic. And so this is a schematic of what I'm calling the COVIDCast ecosystem. And it's about basically supporting pandemic tracking and forecasting to the best extent we can with new data sources. So I'm going to talk about a massive survey we're running in partnership with Facebook, but we also have many other data sources that are new coming in. And I just wanted to acknowledge them as well. Some that are based on electronic medical records, some that are based on antigen tests, some that are based on mobility patterns as captured by SafeGraph, etc. And actually, we had been running a survey not only through Facebook, but also through Google. And if people are curious about the differences between the two, they actually were very, very different systems. I'm happy to answer questions on that in the Q&A, but I'm just gonna leave it out for now because we have enough to talk about as it is. Okay, so this is the COVIDCast ecosystem. Basically, we have data coming into the data floor. We compute a bunch of indicators of COVID activity, which are supposed to reflect different slices of essentially how the pandemic is affecting the country. And then we serve them through a public API to anybody who would want to be able to access them, people who are in public health, fellow researchers, data journalists, and so on. And at the top layer is kind of the most user-facing side, which is some of the models that we're building in terms of short-term forecasts and also interactive maps and graphics. So I'm really just going to talk about our data sources. I'm going to skip the API completely, and I'm going to talk a bit about the symptom surveys, and then Alex is going to pick up where I left off. And this is a reproducible talk. That's probably the most useful thing I can actually say, is this talk is reproducible, and I should give you the link. It's online, which means all the examples that I'm giving in this talk, the code is in there to produce them. I don't think I have access to the chat while I'm screen sharing, but as soon as the Q&A starts, I will paste the link to the talk in the chat. So I'm just going to jump to this. I just want to basically give you a sense for why it's important to get multiple data sources in order to understand a pandemic, number one, and number two, how surveys can help. I know this is a group focused on survey research. So this is what I would call the period of severity. It lays out the different ways in which a pandemic is affecting, let's say, a society in terms of burden or in terms of severity. And so at the very top rung is the highest degree of severity, which is deaths. Right? So getting data on who has died from, let's say, COVID is extremely informative, but it's also lagging. It's not reflecting pandemic activity today. It's reflecting maybe pandemic activity 20 days ago, right? People who have been infected in the population 20 days ago. At this point, the median, let's say, lag between confirmed case and death, at least in the US, if you look at the lag that maximizes correlation between those two data streams nationally, is about 20 days. Below the deaths are ICU admissions. Below ICU admissions are hospitalizations. And below hospitalizations are confirmed cases. And so basically, most of these rungs, we have public health reporting data to capture. So confirmed cases in the US, this is reported at the county level, passed on to the state, passed on to the CDC. Hospitalizations are typically reported at the state level, and deaths are reported at both the county and the state level. So there are public health reporting streams that capture this. It's called surveillance data, another word for it. And a group like JHU's CSSE has put together, it's a heroic effort to put this together basically in a consumable format in their GitHub. What about the rest of the severity pyramid? Well, Below confirmed cases, so confirmed COVID test, would be people who are visiting the doctor who are expressing, let's say, COVID-related illness. And that's what we're calling this outpatient visit or medically attended rung. Below that would be symptomatic individuals in the population who is infected with COVID and is showing symptoms. Below that are infecteds, so symptomatic and asymptomatic. And below that are general population level kind of quantities or behaviors that are relevant to understand. So the entire point of the severity pyramid, the reason that people lay it out this way is that you tend to think about, if you want to understand any one rung, it helps to understand the rungs below it. So if we want to understand, let's say, who is going to die due to COVID, either for a prospective forecasting exercise or a retrospective analysis of our healthcare system, either one, right? It would be good to know who has been admitted to the ICU due to COVID or hospitalized due to COVID. You imagine that somehow that relationship there's a hierarchical nature there, maybe not strictly hierarchical, but typically a hierarchical relationship there that's helpful to understand. If I want to understand who's going to show up as a confirmed case in my county, it would be helpful to know, let's say, who's attending the doctor with COVID-related illness. This would typically happen before one would get a test, or at least before the test would be reported, right? And of course, knowing things about symptomatic individuals in the population would be extremely helpful for that as well, as would, let's say, population level behaviors like mask wearing or social distancing. The problem is, so the severity pyramid basically lays out all the data, all the rungs that somehow categorize different data sources that would be useful for understanding pandemic burden. The problem is that for most of these rungs, we don't have good publicly available data. And in fact, it's really just for deaths and ascertained cases that we have the most complete record. And for the rest, it's extremely difficult to get good publicly available data. And where surveys come in is in actually a variety of rungs, but primarily in the symptomatic rung and in the population rung. So you can imagine that if you could run a survey that was able to reach, let's say, a huge number of people every day, and you could ask these people about to self-report on their symptoms or symptoms in their community, then that would be an extremely useful indicator of, let's say, infections in the population that you could not get access to through any kind of public health reporting data or other data that I'd be aware of. Of course, there's survey bias associated with this in a variety of different dimensions, but it's certainly better than nothing. Also extremely useful for population level behaviors, right? Asking people whether they, for example, how often they wear a mask when they're in public, whether they adhere to social mandates in their local region, whether they actively practice social distancing, what their occupation is, if their occupation somehow requires them to be around other people, etc. So I'm just going to flash, I guess, one plot, which I wanted to show you guys, and then jump to the survey, describe it very briefly, and then I'll be happy to take questions. So I'll just spend maybe two or three more minutes here, and then happy to take questions. So in this talk, which you can get once I share the link with you, I basically walk down the severity pyramid, and I give you example data sources that help you address questions living at those different rungs. And so here's at the symptom rung of the severity pyramid. And suppose you wanted to know, how do my county and my friend's county compare in terms of COVID symptoms in the wild, right? Not somehow, let's say this is not confirmed COVID cases through the county's Department of Health, but let's say COVID symptoms in the population. And so this is actually data that's based off of our survey that we're running in partnership with Facebook, which I'll tell you about in just a minute. I'm able to compute, every day since we started in April 6th through the current day, the fraction of people in my county, which is Allegheny County here, that report that they know somebody else with COVID symptoms. So this is an interesting question. You might be, skeptical as to why we put that on the survey, but this turns out to be very useful. And compare that to my friend's county. My friend lives in Atlanta, Georgia. To look at how many people are reporting they know somebody else with COVID in Atlanta. Okay, and this is actually available nationwide at a huge number of counties, county level. When it's not available at the county level because the data is too sparse, we actually aggregate it up to the state level, and it's available every day. And this is only one of around 35 different, let's say, indicators that we can calculate from this survey. So I'm going to skip over all this API stuff, and I'm just going to tell you a little bit about the survey. I'm going to maybe show you one example, and then happy to take questions. And like I said, Alex will return and pick up from where I left off. So in April, we started a survey in partnership with Facebook, and it reaches on average about 75,000 people per day. And at this point, it's actually over 12 million people have taken the survey since it began in April. And it's a US-based survey. Although there's a parallel international effort that's run by the University of Maryland, and it's received over 20 million responses internationally in over 100 countries. And the two surveys are actually quite in sync. We've gone through, I think, 5 survey revisions at this point, and we work closely with the international team in order to kind of keep them in sync. So the survey asks questions about COVID symptoms, both common and rare, COVID testing, mental health, social contacts and behavior, demographics, and mask wearing is a new question we added recently, which has been extremely useful. The survey is implemented on Qualtrics, which is, we have a license to Qualtrics through Carnegie Mellon. It's managed and run and processed by us in the Delphi group at Carnegie Mellon. Facebook advertises the survey to a random set of users every week. And if they click on this advertisement, then they will leave Facebook and be taken over to our own Qualtrics survey. So Facebook actually never sees any of the response data. They have no access to the data either. It's designed to take about 10 minutes, and it's about 35 questions long. The questions were originally selected for relevance to forecasting and nowcasting, which is our group's expertise, as I explained. But we, thanks to Facebook's encouragement, we actually essentially rounded up questions from a huge number of groups in public health when we launched this survey that tried to get at understanding the burden of the pandemic well beyond forecasting and nowcasting. So this should be useful to all sorts of researchers, not just those who are pursuing forecasting models. And respondents actually provide zip code level data, so we aggregate it up to the county level. And as far as we know, this is the largest non-census research survey ever conducted. It's kind of hard to corroborate that, but this is our current belief. So let me just tell you about 2 things we ask in the survey, and then I'm happy to take questions. Just two quick things I'll tell you about we ask, and then I'll also pick up, like I said. On the front page of the survey, basically, we ask people to self-report on whether they or anybody in their household are experiencing any of the following symptoms: a fever of at least 100 degrees Fahrenheit, a cough, shortness of breath, or difficulty breathing. And we can define a condition called COVID-like illness, which is comprised of a fever along with one of the other symptoms: cough, shortness of breath, or difficulty breathing. This is the current definition that the CDC advocates. So we can compute a percentage of people with COVID-like illness each day in a huge number of counties based on these survey responses. We also, about a week after launching the survey, added a new question to the front page, which is, do they know somebody in their local community who has COVID-like illness? Not just themselves or in their household, but somebody else in their local community. And we call this percentage CLI in community, so the percentage of people who know somebody else with COVID symptoms. And it turns out, and this is the only plot I'll show before I take questions, that even though this is a proxy question, we have people reporting on others, it turns out to be offer much stronger correlations with COVID case rates than does the original CLI indicator. And what I'm showing you in red are the correlations of the percentage CLI and community indicator at the county level with COVID-19 case rates, officially reported through public health surveillance data. And you can see that that's compared to the CLI indicator in this kind of yellow color. It's not only much, much higher than what we get with the CLI indicator, it actually is, in an absolute sense, it's extremely highly correlated, which surprised us with the public health surveillance data, reaching above 0.8 for most of the period after July of this year. So I'm going to stop here. I actually think I took too long probably, but I'm happy to take questions. We can do 10-minute Q&A, and then or I'll leave it up to Eric to decide. And then Alex is going to come back and answer more questions about, or give more on the survey and answer more questions about the survey.
Well, this is just great, and thank you, Ryan, so far for sharing all of this. I mean, I'm struck in part by sometimes things that we think are simple turn out to be not terribly simple. And so a question like how much disease is there within our community, what's the prevalence of something like this is something that, say, as a kid, I assumed was an easy number to calculate. And the more I learn, it becomes a really difficult thing to tackle. And so I'm really intrigued by what you're doing here and eager to discuss it. I guess I'm wondering if we could start with the CLI and the CLI in community measures a little bit and talk about how you've operationalized that. So can you tell us a bit about sort of how you generated what counts as the symptoms that you're asking about and how that's changed as our understanding of the disease has changed from January till now?
Yeah, sure. We chose that actually for kind of two reasons. One was its proximity to a well-known and standard definition of ILI, influenza-like illness. So influenza-like illness is defined as fever along with a cough or sore throat. And this has been the case for, I don't know how many decades, I think several decades. The CDC has adopted this definition of influenza-like illness, and it's also internationally become the standard as well, although there's a little bit of differences maybe in the international definitions. And so our first kind of thought with running the survey was, let's just ask people very simple questions. Do you have a fever? Do you have a cough? Do you have shortness of breath? Or do you have difficulty breathing? And we omitted sore throat because it was not at the time in April believed to be a common symptom for COVID. And we worked with the CDC to confirm that this would be a useful definition for COVID-like illness. And then on the second page of the survey, we actually asked people to self-report on a ton of the more rare symptoms. What we thought at the time were rare, but as the months have been going on, there seems to be growing consensus that some of these are much less rare than we believed. So the second page of the symptom of the survey asks about muscle fatigue, loss of smell, loss of taste, I guess COVID toes. I think it's a list of about maybe 20 or so symptoms that are more rare. And we've kept the CLI indicator in place because it's certainly broader than let's say symptomatic COVID infections. It could include flu, it could include other things, but it seemed like that was the direction we were going for in terms of an early warning system. If there's a rise in kind of related illness, then it seems worth paying attention to, rather than defining something that's very, very specific, let's say due to loss of smell and loss of taste. That said, another extremely important thing that I should make actually known to everybody is that the individual survey responses, so the individual survey response data is available to any researchers that are at a university or nonprofit, provided that they're willing to sign a data use agreement. And that data use agreement is up at this link I pasted in the chat. So people can go and define different indicators. I think that would be extremely useful, of course. So there's currently almost 20 groups that have signed a DUA, I think, with us to get access to it. And the DUA is basically to protect some of the potentially sensitive aspects that come with surveying 12 million people, 35 questions, and asking them their zip code. Right. So the DUA basically is put some language in place to make sure that people are handling privacy in a rigorous way. Outside of that, all the indicators that I mentioned in this talk, like the CLI ones and a few others that maybe Alex will get to, they're actually available in an aggregate form publicly through our API. And the link for that you can find in the talk, so you can play around with them yourselves.
So I guess the other piece that I'm curious to learn more about is your use of this community indication of the CLI, right? So do you know someone? And it was interesting to see how that tracks more closely, you were saying, with some of the county level official numbers. But I'm curious to hear a bit more about sort of what spurred that on and your experience in using that. And then I have a couple more technical questions after that. But
sure. Yeah, the story there is quite interesting. So I didn't mention the survey through Google that we've been running, which we've paused, but we've talked about different ideas for bringing it back online. We've just paused it due to basically not being able to do too many things at once. The survey through Google was run very differently in that we were asking questions through Google's survey, basically product. And Google was allowing us to do so in a way that was a little bit more tailored, customized than what's offered to the general public, which is very generous of them. So we could ask people, let's say at a particular county level, we could actually target, let's say, a county of interest and a number of responses of interest and go and deploy a survey in that county until we got that number of responses. And we were asking people questions about symptoms, and it turned out that that was not a format that Google's Health Ethics Committee was very comfortable with. Basically, asking people about their health was not commonplace through Google's survey platform. It was basically, I think, had never happened before. So we pivoted to asking people about the health of others around them. And that was approved by the Health Ethics Committee. And initially, I was very disappointed in that, and somehow that we had to change that question. I was pretty sure that that would give us garbage. That was my intuition. That somehow, if you ask them, people, who do they know with, how many people do you know with, COVID-like symptoms, they wouldn't think very carefully, or maybe they would just answer everyone, or I don't know. I mean, I just felt like it would not be a very useful data stream. But my intuition is that, I guess I'm explaining away the phenomenon that we're seeing empirically, right? So I'm not sure that this is really completely justified, but I think there's two things going on. One is that it's kind of a pooling effect. We're asking a person to report on many others around them. So it's almost like an immediate boost in sample size. And two, because the original indicator is so sparse, somehow like this pooling is very, very important for the signal, for the SNR, for the signal to noise. Like we've just somehow, it probably would not be useful if this was not a very sparse, let's say, an indicator that we were tracking, but somehow sparsity combined with this pooling makes this a very useful thing to ask.
Yeah, so I mean, I find this fascinating because I'm not necessarily talking about symptoms with friends right now, and so I'm intrigued to see it working to that degree. But there's a question in the chat that Jean-Francois has posed about how can we make sense of the gap between the CLI and the community CLI. I mean, I think pooling is potentially part of that answer, but how do we make sense of the disparity where the community CLI is doing so much better? And I guess the other question I would ask is, why is it doing better over time? What are your intuitions about why it had less reliability initially and is improving as we progress?
This is actually a very, I think this is a very, we're very encouraged that it's doing well over time. We interpret that as it's somehow tracking what we want it to track. So I'll explain that one first. And I see Alex came online. So maybe after this question, I'm happy to turn it over to Alex. And Alex, basically I got up to this slide. That's it. So you can just, slide 32, you could continue on telling them about the survey. First of all, why is it doing better over time? So Alex and I wrote a blog post about this, which maybe Alex can paste in the chat. Here we're taking, to be clear, for every day, we are ranking the counties in order of COVID case rates. We are ranking them in order of these indicators, like let's say percentage CLI. And then we are taking the correlation of those two vectors of ranks. So we are basically assessing whether or not being high in case rate on that day is associated with being high in, let's say, percentage CLI. And what happened in mid-June up through late July is that there was an explosion of COVID activity in the south of the US. So many counties in the south saw a huge surge in COVID cases, and their case rates went up, really high. And so, in the blog post, we basically plotted some measure of spread of case rates across the country over time, and you can see that basically it picks up really sharply in the same pattern right around mid-June. And so, when there's a larger spread, a higher correlation, basically we interpret it as a good thing. It means that it's at this point the signal is swamping the noise, and we actually have more signal to correlate against when we are looking at these indicators. So they're tracking what we believe they should be. If it didn't behave in a way that was, let's say, if it behaved in the opposite way, right? Somehow the correlation is plummeted when this when this spread occurred, we'd actually be very worried, because it would be almost as if, like, before this point we were correlating against noise and then we were getting lucky. I don't know if that explanation made sense. The former question about the gap between the two, I have to say I don't have a great answer for it. We are doing a little bit more work on it now, actually, in that we're trying to figure out if there are systematic differences in CLI across counties that could explain this.
I'll mention, hi everyone, I'll mention another possible explanation as well. We know, for instance, that some people, for instance, say that they have every symptom when they take the survey, which naturally that noise would affect percent CLI much more than CLI community, because percent CLI is like 0.5% or 1% of respondents have a COVID-like illness themselves. But right now in North Dakota, half of respondents, not 0.5%, half of respondents know someone who's sick. And the noise of the 1 or 2% of respondents who are deliberately injecting noise has a much smaller effect. That could explain some of it. I haven't tried to quantify how much of it that would explain.
So I'm curious here, because there's an interesting sidebar conversation in the chat happening right now about the role of social desirability bias in this. And so I want to invite Jean-Francois or Simon to follow up here if they would like, because I think that thread might be interesting to follow for a minute.
Yeah, sorry. So thanks, Ryan. That's some really interesting stuff. The point, so this issue about asking people questions not directly to themselves, but people they know, kind of thing. You know, we've seen this in the polling phenomenons, whereby people are always often reticent to provide their own perspective, but you ask them, who do you think your neighbor's going to vote for? And actually what you're reflecting is what's going on with them, but they don't have to say it's me, it's someone else. And so part of probably what you're picking up in that community piece is them not wanting to say, yes, I have symptoms, because there's obviously a stigma and a potential negative bias that's associated with that. But, the person next to me, yeah, they have symptoms. Not that they do or don't, but it oftentimes reflects actually what's going on with them. So this is not uncommon, that where you, from a predictive perspective, you get much greater accuracy when you do this sort of triangulation process.
Yeah, and we are right now actually about to experiment with that about another question in our survey, which I don't know if Ryan has mentioned yet, which is our mask wearing question. So since September 8th, we have asked all of our respondents, when you're in public, how often do you wear a mask?
Yeah.
And the spread is between, say, 60 to 70% in the central and north central United States, like Wyoming, for instance, was, I think, the lowest for a while, to 98% in Washington, D.C., saying they wear a mask most or all of the time. Now, the question is, to what extent does social desirability affect that? And I would expect probably quite a bit. And so in our next revision, we're going to be asking that question, as well as, when you're in public, what percentage of other people are wearing masks when you're in these public places? And we're going to see whether those two answers are very different from each other.
Yeah. So just interesting, not last week, but the week before, JF was presenting his work, Jean-Francois Daoust, about how to construct those questions and how much complexity you might need to put in there to create room for people to respond in different ways. And I'm assuming that your answer is probably just is it a yes/no response, or is it?
It's like all the time, most of the time, some of the time.
Okay. And then when you say 98%, that's 98% most of the time.
Most or all, those two choices.
Yeah.
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 Now there's some really interesting stuff here, and I want to facilitate this conversation in a few minutes because I'm sure JF is going to have lots to weigh in here. But maybe, Alex, could we turn to you for a minute here to sort of share a little bit more about some of the other metrics that are being used and the other things that you'll be investigating, and then we can pick up that thread of how they're being measured in the Q&A after that.
So switching back to the slides, the latest version of the survey, so September 8th became wave 4 of the survey, and this was in collaboration with University of Maryland in their international survey, which I don't know if we've touched on, but they survey over 100 countries in a similar way. We now can calculate new aggregates. So the new revision of the survey includes test positivity rate, well, includes testing questions, quite extensive, asking, have you been tested in the past 14 days? If yes, did you test positive? Do you know? Why were you tested? So for instance, were you required to by your employer or because of a medical procedure, or did you feel sick or whatever? We ask questions like, in the past 24 hours, have you worked outside your home? Have you gone to a bar or restaurant, etc.? We ask about mask wearing. We have some items about anxiety, depression, and isolation. So in the past 5 days, how often have you felt isolated from others, felt depressed, things like that. And we added a couple additional symptoms based on CDC sort of guidance on what symptoms of COVID are, and things like that. And I'll just touch on a couple of these and what we've found from them so far before going on to other topics. So for instance, the mask wearing question, this is October, I think 15th. Yeah, October 15th. So on the right, we have the percent who know someone who's sick. You can see that's touching 40 to 50% in the north central US. It's actually gone up since October 15th in those states. And we have mask usage in those states as reported on the survey. To the point about social desirability, whatever social desirability effect is happening, nonetheless, we see 55%, I think, in Montana and Wyoming on up. And I'll mention, it's not here in the slides, but what we've seen in the data since September 8th is mask wearing has gone up to 70 or 80% in many of these states in the central US, and actually has slid down a little bit in some other states, such as the Southeast, like Florida. I don't really have an explanation for that now, whether that reflects true trends. You know, that could obviously reflect the causal influence of knowing everyone around you who is sick and then deciding to take precautions. It could also reflect changes in social desirability and many other things. But, you know, if you take those two maps and you correlate them like this, there's kind of a, let's see, this one, which date was this? I think this is the same date, October 15th. So on October 19th, the R squared here is 0.73. Which is quite big. So whether that's reflecting true trends in mask usage, trends in social desirability, or both at the same time, which is probably likely, that is an astonishingly large correlation for these two signals measured is sort of in the wild with survey data. Yeah, so that's sort of the end of the survey data stuff, but I'll mention a couple other things about the surveys and how they're being run.
Go to the appendix, you can show them the slide for how to get access to the microdata.
Good. That's what I was going to say now, but glad you have the appendix. So what I'll mention is the way the survey is being run, we're operating it with Facebook and University of Maryland, but we make the microdata available, including all the survey responses. And we should update this. It's now 12.5 to 13 million survey responses since April. And if you have research questions that you could address with this data, you just fill out a form saying what you want to do with it. And there's a data use agreement saying that, you know, you won't release the raw data publicly, and some conditions on use of the weighting and so on. And then we can give you all of it, subject to those mild conditions. And we would really like lots of people to do that. So if you see potential uses for this in your own work, things you could do with it that we haven't thought of yet, because there's lots of them. We know of some groups. There's about 15 to 20 groups now that have access to this data. And I know of people studying occupational risks, which occupations seem to be at highest risk, which occupations are getting tested, those types of things. I know of people studying mental health from isolation and lockdown and so on. I know of people like Delphi doing forecasting, trying to forecast using the signals from symptoms. People building dashboards. There's someone who built a state of Indiana dashboard from their Indiana specific data and uses some of our data in there. So there are a lot of potential applications. Disparate impacts on minorities and disadvantaged groups could easily come up. Policy questions about which demographic groups are adhering most to policies, or should we do outreach to? All of these things you can easily imagine researching and studying, and we can't answer all of those questions ourselves. The COVID-like illness signals, the aggregate ones, are available publicly through our API, as well as some testing related signals aggregated to county level, and mask wearing signals county level. You don't need this data use agreement to get those. You can just pull them directly out of the API in a fashion that looks just like this. You just load our R package and you can pull them. But the microdata, if you want to do correlations or breakdown by demographics and things, you can fill out our form and get access. And I'll mention we're also adding in, soon we're going to be asking about flu vaccinations, because this flu season, the CDC and other agencies really would like everyone to have flu vaccines so they don't have to deal with flu. And they would like to figure out where to target outreach campaigns, flu vaccination campaigns, everything. So we're going to be asking about flu vaccinations. As soon as a COVID vaccine is available, we're going to be asking about that. Many other things that'll, as we adapt to circumstances in the next few months.
Thank you so much for that, Alex. I think for the sake of time, what I want to do here is I'm going to ask a couple of questions first about the sort of prospective sampling bias and the use of social media samples, and then about the questions of how we calibrate data quality here. And then from there, we can throw it open to get back to some of these discussions of social desirability bias and the like with the group. I should just ask for a moment, do you know if the Maryland team has similar arrangements in terms of data access? Because we've got folks on the call from several different countries and the like. So if they're interested in breakdowns of non-US data.
In fact, it's one form you fill out. You just check the box for which survey you want data from, or both. You would then actually, if you, for instance, if you want both, you sign a data use agreement with Facebook, CMU, and the University of Maryland. There's 3 forms that your university or organization has to sign, but one form to get all of those.
Beauty. Okay, so let's start off by talking a little bit about the use of the social media sampling here. I'm curious for what you've learned thus far about who's having access to these Facebook surveys, for instance. How does that differ from what you were doing with Google? What kinds of potential biases and or advantages do you have doing this kind of social media-based recruitment?
So the obvious advantage is size. It's simply, we can ask 12 million people since April, and there's really random digit dialing or any other polling method you could think of. You just can't do that at the scale and geographic resolution that we're getting. So we have individual zip codes from respondents that aggregate to counties. You couldn't do that at the scale pretty much any other way. Did Ryan mention to you the survey weighting scheme that we have?
Not yet, no.
Okay, that's a good thing to mention because that'll address a bunch of different things. So there's some obvious problems that Facebook's active user base is not the United States population. It's not the entire United States population. And so a random sample from Facebook's active user base is not the same thing as a random sample from the US. And that's both the difference in population, and also this is a voluntary survey, so if they're sampled, they might not take it. So there's a non-response bias. So there's a couple ways we try to address those. One is So I think probably as Ryan mentioned, or as I will mention now, Facebook does not get the survey data, like the actual responses, but they do know who took it. So because there's a unique identifier that comes to us, we actually can't use that to figure out what Facebook user or respondent is, but we can send it back to Facebook and they can provide us survey weights. They use information they know about where people are, their age and their gender to calculate, and then compare that against state demographics. So for each census, for the state census demographics for gender and age, they then do survey weighting based on that. And give us weights designed to make the demographics of the respondents proportionate to that state's demographics. They also do, as part of the same process, in the same weight, inverse probability weighting for non-response. And what that involves is Facebook, being a large technology company, is in the business of predicting who will click on things. And so they have a model whose details are not publicly available, to predict whether respondents will take the survey or whether the sampled individuals will take the survey. And from that, you can construct inverse probability weights that adjust for whether someone is a likely participant based on their Facebook behavior or not a likely participant when they're sampled. Those weights are then sent back to us and we use them to construct weighted estimates. Obviously, the demographic adjustments only are for age and gender. There are many other variables you could want to adjust for that are not included in those weights. And the probability weighting depends on the quality of those models, which we do not have access to. And so what we've been saying a lot is we see these signals not so much as serving the same purpose as, for instance, election polls, which are now in the news for whether or not they're unbiased estimates of an underlying latent quantity. We see them as more as trend detectors. There is probably some unknown bias that results from, for instance, the Facebook active user population not being the US and non-response and so on. But if that bias changes slowly in time, then a sudden change in symptoms probably means some real underlying change in people's symptoms. Even if, it says 40% of people say this, but actually the true number in the population in that area is 32% or 47% or something. We think the changes are meaningful and useful to study, even if the absolute quantities, we try to adjust them, but it's unclear how you would tell if they're correct.
Yeah, that's really interesting stuff. And I mean, it harkens back to some of the conversations we've had about, for instance, self-reporting of protective behaviors and precautionary behaviors, that perhaps there's a little bit more to be read from the trends than from the raw numbers. But I want to follow that thread just for a minute here before I throw it open to any questions from the group. And do feel free on YouTube to share questions in the chat box, or on the Zoom call to share them in the chat too. One of the things we've talked about in previous sessions is the idea of calibrating and checking the validity of these measures against real behavior, right? Trying to find some sort of objective measure against which we can see how these methods are performing. And that has got to be a struggle even with something like caseloads, because caseloads are highly reflective of localized testing regimes and the like. So I'm curious if you can talk about any work you've done to try to calibrate that and how you deal with the variation in, say, testing regimes, location to location. And then there's a second bit I'll get to in a minute.
So you mentioned testing regime. So for instance, if we look at, I think the red line here is our symptom measures from the survey, and this aquamarine line is caseloads in the various counties. You can see, to the point it's difficult to calibrate against, that county caseloads, the reporting is quite inconsistent. So we see funky drops and funky spikes that probably represent, for instance, testing backlogs. We see one down here in Hidalgo County. These represent testing backlogs, sudden changes in reporting. We've seen places that appear to have negative cases on days because they report only cumulatively, and they changed their reporting, and so suddenly their cumulative count went down. We see a lot of bizarre things like that. So for instance, calibrating symptoms, it's not clear what a gold standard measure would be. What do you compare against? Now, anecdotally, calibration questions, for instance, mask wearing, what do you compare against to see, am I measuring true behavior? Well, one thing I can report is anecdata. There was a Dutch psychology professor who went on Twitter and said, I'm going to go to the mall and count how many people are wearing masks. Anyone want to take bets on, or actually give me a beta prior for the proportion of people wearing masks at the mall? And people were then quoting numbers, and he went to the mall and got 41% or 40% was what he observed among people there. So I went to the International Survey Data API, pulled the number for the Netherlands, and it was 41% say that they wear a mask in public moisture all the time. So I decree I'm not going to look at any other data. We've now won. Now, actually, to that point, more seriously, we actually just learned recently about an effort in Philadelphia that's using surveillance cameras. They're auditing surveillance cameras in public places and just tagging manually who's wearing a mask, and getting different numbers. And we're going to look soon. We're actually going to start trying to talk to them to figure out how different are our numbers from their numbers, what they actually see in public places in more systematic fashion than just going to the mall for a couple hours. And see how that
I wonder
compares.
what potential is there as well with, you had mentioned the questions that you're adding in about testing and knowing whether other people have gotten tested. Testing seems to be something where you could look at the rate of self-reported testing versus a much more dependable number of tests done released at the county level.
You would think so.
Is this my Canadian bias showing through here?
Yes. So when we well, partially, when we first produced, we first got the testing data in and we made a map and we looked at it and we're like, does this look right? And I pulled the number for North Dakota, and the number for North Dakota from the survey claimed that 25% of North Dakotans say they've been tested in the past 14 days. So I went to the North Dakota Department of Health website. I pulled the testing numbers. Actually, I think I went to the COVID tracking project because it's easier to find stuff there. I pulled the numbers, and that was like 5 times more tests than actually North Dakota says were conducted. So then I said, okay, what's going on here? Well, North Dakota only reports PCR tests in their public system. That's the ones that look for genetic fragments. They do not report antigen tests, which are the sort of rapid tests that you see coming more and more popular now. And so then I asked, okay, are there that many rapid tests, that many antigen tests, or is our number just wrong? I actually don't know. We tried to find data on antigen testing in North Dakota. You can find news articles saying, well, the federal government has sent 1 million antigen tests in North Dakota, but I have no idea how many of them have been used. They have not been publicly reported in any way that I could find. There are some states that do publicly report antigen tests, but I don't know how many they report. If it's all of them, because there are different manufacturers. Some of these are point of care tests that are done at doctors' offices. Some of them have to be sent in. I don't know. It seems like there may be some overestimation. We looked at some states that report better. They report more, they report antigen and PCR tests. It's like we're still overestimating the number of tests, but I can't really tell by how much, because there's not just a number for the number of tests.
Fascinating stuff. Well, look, unfortunately, we're running out of time here, so I'm going to ask you a 15-second brutal question and then wrap things up and announce the upcoming speakers for the group. So here is the unfair question to ask you for a concise answer to. Both you and Ryan have discussed some of the ways that this project has sort of changed and evolved over time and the lessons learned. If you could give advice back to yourself in March about doing this project, what are 1 or 2 of the key lessons, the things that you wish you had known then about how to launch this project that you know now?
I would say that the key thing about a project of this scale is that we at Delphi, despite growing to enormous size in, what Delphi went from 6 people to 30 something now, I don't even know how big now, this is a project that is much bigger than us. We are collecting 35 questions from tens of thousands of respondents every day, getting as many people involved to answer their own research questions as quickly as possible is the only way to do it. And we've been catching up to that and getting lots of people involved. But it would have been great to have partners, back in March or April, right when the survey came out, all doing their own analysis of the data as soon as the data became available, and publishing on it and making actionable decisions.
Yeah. Yeah. I mean, one of the things that gives me hope out of all of this is the attitude towards open and collaborative science that I've seen from many of the project teams, and it's no exception. So, Alex, thank you so much for being willing to share with the group here. It's been a fascinating conversation, and I'm sure there's more we could talk about for a long time here.
Well, glad I could join.
Yeah. In terms of group activities coming up, next week, we're going to change courses entirely. The survey working group next Wednesday at 4 p.m. We're going to dive into anthropology, and we have a couple of anthropologists joining us to discuss how to conduct research in a time of COVID with cascading disasters. So how our surveys need to be informed by looking at the intersection between multiple different kinds of disasters. The week after that, we're going to be heading over to the University of Milan and looking at some discussions about rolling cross-sectional designs for surveys and how to implement those. And then we're going to finish up for the fall semester in the first week of December by meeting with folks from the Pandemic Journaling Project and learning about diary studies in the context of COVID. So for now, let me say thank you. I'm so glad to those of you who could join us live and are watching asynchronously. Thanks to Alex and Ryan for sharing this exciting project and opportunities to get involved. And we'll see you next Wednesday, 4 p.m. Eastern, 1 p.m. Pacific, for discussions of cascading disasters in a time of COVID. Thanks so much. Okay, and we're off of the live stream now.